How can we improve the outcomes of older men? Well, we were going to have a talk, and on the programme you can see that Danielle Harari was going to talk to us, who is a geriatric oncology consultant. I'm sure we would all be very grateful to have a geriatric oncology consultant in our MDT, who worked at Guy's and St Thomas's. Unfortunately, due to clinical pressures, Danielle is unable to be with us today. And at the last minute, my good friend and colleague, Dr. Ajay Aggarwal, has stepped in and he is going to present Danielle's slides. So Ajay, thank you very much for doing this at the last moment. Ajay is a clinical oncology consultant, also at Guy's and St Thomas's, and a key member of the National Prostate Cancer Audit. So Ajay, the screen is yours.
Thank you very much, Heather. I'm just trying to, can everyone see the slides? That's the first thing. Yeah, great. For some reason, my video's not coming on, but I'll save you people looking at me looking good today, but that's fine. No, anyway, so let's start this off. So unfortunately, Danielle Harari can't be here, or Tanya Kelsey, and why that is unfortunate, because I think this is a revolutionary service, and it's a service that ultimately benefits patients and looks at those underserved communities that the data reflects on. I think there are three sort of top line things to mention first and foremost, which people might not be aware of or are aware of. The life expectancy of someone aged 75 is approximately 12 years. I think that's the first thing. I think second of all, Matt's data was very helpful, but also I think the devil is in the detail, and it shows that from a top line perspective, we do see that there does disproportionately seem to be that elderly men are not receiving treatment, but we're not necessarily able to work out the exact reasons for that with that data alone. And so we need further embedded work. If we look at what the rates were, you know, men under 70, about 80% got treatment for locally advanced disease. That fell to about 60% in those 75 to 79, and then fell to about 15% in those over 80. So the question is, can we increase that rate? Can we improve that accessibility? And are we able to select those patients who are going to benefit better than we are doing now? And I think one thing that's being offered at Guy's and St Thomas's is the Gold service. So this is dedicated geriatric oncology liaison development service that works and embedded with oncology, and particularly focused on men who are receiving non-surgical treatments for cancer. But let's take the top line policy element to this. So we have the cancer strategy in 2015 to 2020, and their recommendation quite clearly from NHS England is that there should be a risk assessment, should include a comprehensive care pathway for older patients. So there is a directive for this. There is an evaluation that our population is getting older, that's driving our cancer cases, but actually potentially patients who may benefit are not receiving treatment. Similarly, with the SIOG guidelines that Heather was referring to, the assessment should be on individual health status and not according to age. And we've now had a recent publication in the Lancet in November, a randomized control trial, essentially through the use of a geriatric assessment intervention for older patients. And it showed for those with advanced cancer embarking on cancer treatment, there was a reduction in serious toxic effects where an assessment intervention was used. And that assessment may be paper-based, it may be through a consultation, but there are elements that if we actually look towards personalizing the needs of individuals, we're going to reduce toxicities. So what did GOLD, as I said, the Geriatric Oncology Liaison Development Service, aim to do? So it aimed to medically and functionally optimize and support older patients for appropriate non-surgical cancer treatment with well-informed joint decision-making. It initially started as a pilot with funding from the Department of Health to address this issue of undertreatment in older people. And this is not just germane to cancer, we've seen it across the board in lots of different specialities, but this was sort of a breakthrough in terms of this cohort of patients. So if we look, this is evidence-based, so this is a study that was published in the British Journal of Cancer, but what does the GOLD Clinic do? Well, it accepts referrals not just from oncologists, can take them from the clinical nurse specialists, radiographers, because actually it reflects that there are more than one team member who are interacting with that patient and can see the different scope of needs or requirements that might be necessary. The clinic is truly multidisciplinary, geriatricians, clinical nurse specialist specific with geriatric oncology expertise, as well as occupational therapists and physiotherapists. The referral criteria is those aged at 65 or those and above, or 55 and above with comorbidities, and all tumor types are accepted. And it's about assessment and co-management of comorbidities and wider issues in terms of social care, polypharmacy, but it's also looking at the holistic optimization to try and improve cancer treatment tolerance. Generally, referrals can be selected between 1 week, 2 week, and 3 week, and there's a two-way information and certainly follow-up by the team with the primary care, social care, but also with the specialist teams as well. So in terms of this assessment, when they looked at a cohort of patients, they found that patients receiving review in the gold service were able to complete their planned treatment, more likely to do so. So close to 35% versus 17%, so quite a significant improvement. And treatment modifications, and I think this is very important for those who are managing patients in the clinic, were needed less frequently. So 43% versus 60%. So two important outcomes that we wish to see. These slides are essentially process maps as to when patients may be referred. So for those in amongst those who are having radical treatment for which the oncologist may refer, or the clinical nurse specialist, there is also a defined pathway to capture those who are going to be on ADT alone or watchful waiting, which the prostate cancer clinical nurses can refer to. But there's also a radiotherapy pathway specifically for those over 70, where they referred at the time of the booking appointment as well to the Gold Clinic. So it's an all-encompassing referral system. And as part of that, there's an embedded prong. So within the comprehensive geriatric assessment screening tool, they use something called CRANE. This is a patient questionnaire using validated questions from the comprehensive geriatric assessment. It takes 3 to 5 minutes to complete in the waiting room, and it looks just beyond the age. It looks about histories of falls, activities of daily living, how do people travel, do they have a phone, are they isolated, aspects of cognition, confusion, memory, depression, anxiety. So we're talking about cognition, we're talking about mental health, we're talking about mobility, we're talking about all those factors over and above. Do they have diabetes and is it well controlled? Oh, they had a heart attack 15 years ago in stents. Actually, they're very stable, they're fine. And also looking at polypharmacy. And I think the multidisciplinary impact of that team really helps. And I think the assessments that one gets as a referrer are very positive. In terms of ADT, I think I had a lot of learning experience for myself in terms of what can be done to optimize patients who are receiving ADT. So it's everything from cardiac status, lipids, blood pressure, to those with diabetes, making sure that they have blood glucose machines at home. Bone protection is extremely important in preventing falls for that group. But also the fatigue pathway. I think there's a particularly interesting assessment of anemia. B12 folate levels are done, assessing mood, strength and balance. What are the reversibles, and to what extent is fatigue based on comorbidities as well? The OTs and physios look at aerobic exercise and try and reduce fatigue and improve quality of life. And we're back to this polypharmacy aspect, because I think when we ask patients for the list of tablets, they're often quite significant. And actually what comes about is that I think we need to have more interaction as to what are the appropriateness of those medicines are and whether further optimization is required. With regards to radiotherapy, I think it was very interesting, the areas that it can be particularly looked at. My mind just immediately goes to urinary bother, partly because actually NHS pads are free on the NHS toilet cards, allowing people the opportunity to use a toilet free of charge because they're receiving radiotherapy, skincare. These are important factors, but also patient-focused concerns. What happens on public transport? What if it takes too long? What if I need the toilet? What's going to happen to my wife with dementia? Who's going to pay for the cost of the transport? Difficulties in terms of the practical setup of radiotherapy, that might be osteoarthritis in the hip or shortness of breath on lying flat. These are factors that come down to the compliance of treatment effectively. And actually by looking at these up front, we can put in solutions rather than saying, oh, well, I should never have treated that patient because they were always doomed not to complete it. That's more of an excuse actually, unless we've actually evaluated all the different elements of that pathway. And then further things around fatigue and prehab exercise. I think this is interesting about docetaxel, and maybe before the pandemic, obviously one of the questions following Stampede is the proportion of patients who are receiving docetaxel was about 35% nationally across MDTs. And Dr. Harari has actually picked this up quite well, which says, discuss the option of docetaxel chemotherapy with people who have newly diagnosed non-metastatic prostate cancer, who are starting long-term androgen deprivation therapy and have no significant comorbidities and high-risk disease. And as she's reflected in what she's written, it might be difficult for oncology, as most older patients will have comorbidities. But the point that she's making is that these can be risk assessed and optimized for SACT. So to some degree, that 35% could have been much higher if actually we had a much better way of appraising comorbidities and people's tolerance of treatment. And we ask a direct question when we refer, please assess for fitness for treatment, or please optimize comorbidity. And they ask back, will our decision-making help inform whether you treat or not, or is this just an optimization discussion? There are different pathways, so this is just an example, I think, a flow diagram or a pathway that they use about diabetes management, particularly for those receiving it on steroids, and actually that, you know, we need to start off with an HbA1c, and actually for those at high risk, i.e. those on insulin or borderline diabetic on oral hypoglycemics, we need to be considering a diabetes referral sooner rather than later, because this could actually compound existing comorbidities quite quickly. And I think these algorithms are extremely important and things that we could probably integrate into oncology during our assessment. So just a couple more slides, and I think this was one of the main findings, or the provisional finding from our assessment from the NPCA organizational audit. So effectively, and forgive me if I haven't got this quite right, between 120 to 140 NHS trusts have been asked about the availability of particular services, whether it's radiotherapy, surgery, diagnostic pathway. But one of the questions was, do they have an oncogeriatric service currently available to assess the fitness of elderly patients for chemotherapy or radiotherapy? Provisional data suggests about 10% have. And so Danielle's come up with some ideas, because it's not straightforward to necessarily set up these services, but actually I think she feels, and rightfully so, that a comprehensive geriatric assessment or comorbidity screening can be done within oncology, and that can be adapted for particular risk profiles of patients. A lot of the optimization can be protocolized, and I think that needs to be developed with a geriatric service, but also it's not just the oncologists who need to manage many of these things. It does require occupational therapy and physiotherapy and social community support. For the more complex patient, oncology should be in a position to link up with local geriatric services, particularly things like falls clinics, memory clinics. And it's about understanding different languages. I think that's one of the big things in medicine, isn't it? What do you do? What value can people add? And it's to understand where pathways can then be aligned to facilitate this for patients, because in and of itself, 4 or 5 referrals to these individual clinics is quite a significant time element, especially when you're not sure about prioritization. But by creating those referral pathway maps, that could improve that quite considerably, especially where there's excellence in communication. I want to just bring this to the final slides, which is around training. And so this was, again, published in the British Journal of Cancer by Dr. Harari and Dr. Kelsey. And the question was, can oncologists assess and manage older people? And they asked about geriatric training for oncologists. And I think the figures are not surprising, but they're stark in itself and probably point to part of the issue potentially in terms of undertreatment. So 65% have never received any training on the needs of older people with cancer. I can say I've never had any either. And then they've asked about confidence. And I think this is important because it may reflect in the MDT in our decision-making, whether it's mental health, elderly patients. What is our confidence in assessing different people? So about 25% were confident for older patients or managing people with multiple comorbidities. Those with dementia, it goes down to 10%. These are significant deficits, 75, 90%. But what would be helpful? How can we embed this? And so there's more and more talk of embedding geriatrics into oncology training with a particular focus around geriatric assessment. How do you use these tools in the first place? Falls, prehab, polypharmacy, and cardio-oncology. So I think there's a huge scope for improvement. And I think from an implementation science perspective, it starts from the training perspective and having pathways of care in place and recognizing the importance and value of this. So thank you very much. Again, it's a shame that Dr. Harari could not be here, but I hope we have a flavor of what she wanted to present.